Good morning. We will start this session by discussing a very important disease in medicine, which is hypertension. And as the name indicates, hyper means above or more than, and tension here refers to pressure, and therefore hypertension refers to an arterial blood pressure that is higher than normal. So hypertension means high arterial blood pressure. And usually when we mention blood pressure, we talk about arterial blood pressure because it is arterial blood pressure that determines how much blood volume will reach the cells per unit time, and therefore how much oxygen will reach the cells per unit time. And therefore, when we mention tension or pressure, we are mainly talking about the arteries, and especially the large arteries in the human body. We all know that the normal blood pressure is determined by two numerical values. So the systolic blood pressure, which is the maximum pressure obtained during systole, and the diastolic blood pressure, which is the minimum pressure obtained during diastole. Under normal conditions, the systolic pressure is around 120 and the diastolic pressure is around 80. Why am I saying around? Because there is normal variation. So we usually say, for example, that the systolic pressure varies between 100 and 110 millimeters mercury, whereas the diastolic blood pressure varies between 70 and 80 millimeters mercury. Of course, there is variation. There is diurnal variation, meaning that there is variation in the same individual between the morning hours and the evening hours, between stressful situations and relaxing situations or sleeping. There is also variation between individuals according to the genes they have inherited from their families. There is variation according to the age group, but for all these normal variations, they have to be included within the normal range, which is 100 to 110 for systolic and 70 to 80 for diastolic. When do we diagnose a patient as having hypertension? When, as you see on the screen, when the systolic pressure is 150 or above, and when the diastolic pressure is 90 or above. Of course, there are certain cases where, for example, you have, and here in those two values indicate that in order for you to diagnose a patient as hypertensive, the blood pressure should be 150 over 90, meaning that both the systolic pressure and the diastolic pressure are elevated. But there are other occasions, for example, when you find that we have only systolic hypertension, meaning that the diastolic blood pressure is 80, for example, and the systolic blood pressure only is elevated 150 or 140 millimeters mercury. This is called systolic hypertension. Sometimes in other instances, we might find that the systolic blood pressure is normal and it is the diastolic blood pressure, for example, that is elevated. This is called diastolic hypertension. But of course, we will not discuss those situations that are a bit more developed and outside or more advanced, and they are outside the scope of your curriculum. So the systolic and diastolic blood pressures should be elevated and on 3 different occasions, as we said. So don't rush to the diagnosis of hypertension. Don't tell your patient that you are hypertensive from the very beginning. You have to ask him to go home first, to relax, and then to come on another day or on the following day and But of course, don't leave the patient for a long period of time because he might be truly hypertensive. Hypertension is one of the widespread diseases all over the world, and in Egypt in particular, and there is a great combination or a usual combination between hypertension and diabetes mellitus, and both have similar effects on, they both occur together frequently, and they both have similar damaging effects on the blood vessels. Hypertension is a leading cause of death all over the world because hypertension is known as the silent killer, as you see on the screen. Why a silent killer? Because it might insidiously cause death without symptoms, especially in patients who have chronic elevation of the blood pressure, especially in patients with chronic hypertension, especially if they're not well controlled, and they might have a bout or an attack of a sudden elevation of hypertension, which we sometimes called malignant hypertension. And this might necessitate that, of course, malignant hypertension here does not mean that there is cancer, but it means that this hypertension is very high, the blood pressure is very high, and it is elevated over a short period of time, and it has damaging effects on the blood vessels, and of course, damaging effects on the organs. Patients with very severe hypertension should be immediately admitted to the intensive care unit. So if the patient has no symptoms, all the complications of hypertension can occur, and even death. For example, here, this is a post-mortem brain, a post-mortem sample, meaning that this is a sample of the brain after death, and it is obvious in this sample that the patient has a bloody mass in the center of the brain. That bloody mass might be a hemorrhage, it might be a blood clot, but it was so massive, there was massive bleeding, massive hemorrhage, or there was a huge clot in the brain that affected the centers of the brain. And if it affects a vital center in the brain, the patient either dies, if, for example, it affects the respiratory center or the cardiac center, or it might, as you see here, this is not affecting the brainstem, but it is affecting the cerebral hemispheres themselves. So it might leave the patient with hemiplegia on the opposite side or loss of sensation. There are warnings when there are symptoms of hypertension. The symptoms are very famous. Hypertension is famous to cause a headache, to cause dizziness, to cause tinnitus. In the ear, you feel like a sound in the ear, continuous sound in the ear. But in severe cases, like in malignant hypertension, for example, or in severe elevation of the blood pressure, you might find that the patient complains not only of dizziness, but of blurred vision. Or sometimes the patient might have chest pain of angina or even chest pain of myocardial infarction. The patient might have disturbed heart rhythm or arrhythmia and palpitations, or even vomiting. If the patient vomits, the hypertensive patient vomits, this is extremely serious, because vomiting in such a case would be an indication of increased intracranial tension or increased pressure inside the skull, and the increased intracranial tension is one of the serious conditions in medicine. Of course, hypertension also has very harmful effects on the blood vessels, and that's why the patients are liable to get, let's draw a blood vessel, And if there is constantly, if the blood vessels are constantly exposed to high pressure, then there would be damage of the inner endothelium of the blood vessels. And that damage of the endothelium of the blood vessels might result in clots, because the blood usually flows on a smooth inner lining of the blood vessels. If that lining becomes rough, then it would lead to clotting because of damage of the platelets. And furthermore, this pressure might also cause bleeding. So these are two major risks that the patient might have: cerebral bleeding, intracerebral bleeding inside the cerebral hemispheres, or even outside the cerebral hemispheres, but inside the skull. Or there might be clots, either clots in the brain or even clots in the blood vessels. The same changes that occur, the same stress to which the cranial blood vessels are exposed, occur in the in the coronary vessels, and therefore the patient might have a clot in the coronary vessels, which results in myocardial infarction. Of course, just like diabetes mellitus cannot be treated or cured, but can only be controlled, similarly, hypertension cannot be cured. So you cannot say that today I am completely cured, I no more have hypertension. No, but you can be controlled. So hypertension can be controlled. That this means that you might be a hypertensive person, but you might have you might be normotensive, meaning that upon medication you become normotensive. But once you stop, and this is an important point to mention, when we say that hypertension is controllable, this means that it is controllable via medications, and therefore you have to warn your patient that even if, or not even if, upon taking medication, he would improve, but improving and disappearance of the symptoms and normalization of the values of the systolic and diastolic blood pressures do not mean at all that the patient would stop treatment, because once the patient stops treatment, the blood pressure would elevate again, or would be elevated again. Similarly, or similar to diabetes mellitus, again, we start by the general measures, as you see at the bottom of the slides, meaning that, first of all, we have to measure the blood pressure 3 times to confirm the diagnosis of hypertension. We have to start by general measures of treatment. So if we discuss the treatment of hypertension, we would start by the general measures for treatment of hypertension, and then we would end by the specific medications for hypertension. The general measures for treatment of hypertension are seen on the last paragraph. You start by salt restriction, because sodium in particular is very important for constriction of the arterioles. And if the arterioles are constricted all over the body, this represents a high resistance to blood flow, and this elevates the blood pressure. So automatically, once you start restricting salt, you might have a normal blood pressure if your blood pressure is mild, because we have mild cases, we have moderate cases, we have severe cases. Of course, in severe cases of hypertension, salt restriction alone would not be enough. But in mild cases of hypertension, or in early cases of hypertension, salt restriction would be enough. So as we said, salt restriction will deplete the salt content of the wall of the arterioles and will result in dilatation of the arterioles. Weight loss is another measure for normalizing blood pressure, because when you lose weight, there is diminished burden on the heart. The heart is not forced to pump a large volume of blood. The cardiac output is diminished, and this diminishes the blood pressure. And sedation, especially sedation that acts centrally in the brain, because this will dilate the peripheral blood vessels, the arterioles, and will also act centrally to calm down the patient and diminish the blood pressure. Of course, I needn't explain the capillary circulation because we talked several times before about the hierarchy of the arteries, the aorta that gives rise to arteries, and the arteries, the large arteries that give rise to medium-sized arteries, and then to small arteries, and then to arterioles, and the arterioles branch into capillaries. And we talked several times about the capillaries. Of course, we said before or on the previous slide that the arteriolar wall is rich in smooth muscles, and that those smooth muscles allow the arterioles, as we said, in the muscular system to contract and relax, and therefore to constrict and dilate. And we said that sodium ions are very important for constriction. We also said that this diameter, or the status of contraction of the smooth muscles, will determine what we call the total resistance in the body, or more specifically speaking, sorry, this is an R, the total peripheral resistance, and the total peripheral resistance, or TPR, will determine the blood pressure. So it's easy. Whenever you eat, your diet is high in salt, the smooth muscles will constrict more, the arterioles will constrict more, the total peripheral resistance will increase, and your blood pressure will be elevated. So if I ever ask you about the component of the cardiovascular system that is the one that is important for control of the total peripheral resistance and the blood pressure, you would say the arterioles. But if I ask you about the blood vessels where exchange occurs, so you would say the capillaries, because the capillaries, of course, you're frequently asked about the structure, function, adaptation of the capillaries. They are thin-walled, they have fenestrations, they're made of one layer of endothelial cells. The surface area is very large because they spread all around the cells. So here we talked about the extensive capillary bed, and by extensive here we mean the large surface area because they surround the 100 trillions of cells that are present in the human body. We also talked about the exchange of materials, and the exchange is allowed because of the fenestrations. We also talked about the one cell thick membrane, and that is important for diffusion, because the thinner the membrane or the wall, the faster the rate, the higher the rate of diffusion actually. We all know that capillaries are tributaries of venules or merge into venules, and that the venules merge or group into veins, and the veins are the blood vessels that carry blood to the heart. This is primitive information now for you, and that 99% of the veins in an adult person carry deoxygenated blood, and that the veins from the upper part of the body merge into the superior vena cava. The veins from the lowermost part of the body merge into the inferior vena cava, and ultimately, as you know, both the superior and inferior vena cava pour their blood into the right atrium. And when you draw them, you have to draw them on the same straight line. This is the superior vena cava, and that is the inferior vena cava, and they are the largest veins in the body. And on this slide, we will talk about capillary exchange, or exchange of material across the membranes of the capillaries, that mainly occurs via the fenestrations. Of course, you know that if we are talking about the capillaries that surround the tissues, then we are talking about capillary tissue exchange, capillary tissue exchange. And in such a case, you can see that the oxygen molecules and the nutrients will pass from where they have a higher concentration in the blood to where they have a lower concentration in the cells. And then after cellular respiration has been carried out, carbon dioxide and waste will have a higher concentration around the inside and around the cells, and therefore they will diffuse from where they have a higher concentration to where they have a lower concentration in the blood. And that is the reason why blood in the capillary bed is gradually changed from oxygenated blood on the arteriolar side to deoxygenated blood. This is a question that I always like to ask you, especially in the final test, on the final tests. Of course, not every time, but this because it's a bit more difficult, or the level of difficulty is a bit higher than the rest of the questions. So I can get this diagram, the one to the right at the bottom of the slide, and tell you what kind of blood is present at the arteriolar end of the capillaries. You would say oxygenated. What is oxygenated? It is blood rich in oxygen and poor in carbon dioxide. And then I might ask you about the other end, or the venular end, or end B of the capillaries. Why? What kind of blood? It is deoxygenated, poor in oxygen, rich in carbon dioxide. And then I might ask you the final question, which is justify the cause of this change. So why did the blood change from oxygenated to deoxygenated? Then you would describe capillary exchange. And in your answer, I would like to see, or it is important to see certain terms like diffusion, like down concentration gradient, like from higher concentration to lower concentration, and to focus on oxygen nutrients from one side and carbon dioxide and waste from the other side. Now we're going to talk about something we did on a lab at the beginning of the year when we were discussing the importance of muscles in the muscular system, and especially the muscles that lie in the walls of the arteries and the veins. And by having a look at that beautiful slide that shows both the artery and a vein at the same time, we can compare them to each other and contrast them. But as I said before several times, in order for a fair comparison to be done, you should use the same level in the hierarchy of blood vessels, meaning that if this is a small artery, then you have to compare it to a small vein. You cannot compare a large artery, for example, to a small vein. Of course, you can see, first of all, that the lumen of the artery is rounded, whereas the lumen of the vein is collapsed, more or less collapsed. Collapsed means not fully rounded, but a little bit about to close. This is collapsed. And why does this occur? Because of the thickness of the tunica media. The smooth muscle layer in the wall of the artery is thicker than the smooth muscle layer in the wall of a vein of the same size. And because of this, the artery, the diameter of the artery remains open even if the artery does not contain blood. And because of this, arteries can contract more than veins. Not only do the arterioles or arteries contain more muscles than the veins, but they also contain more elastic fibers, and this infers more elasticity to the arteries, and therefore they can stretch when during systole, and they can recoil during diastole. So in general, the wall of the vein is thinner, the wall of the vein is less muscular, and the wall of the vein is less elastic. Furthermore, when we start at the heart, the pumping pressure is high, and then this diminishes a bit in the aorta, and then diminishes further as you go down the arterial system, and then diminishes further and further as you go through the capillaries and the veins. And therefore, in general, as a general rule, the pressure in the veins is lower than the pressure in the artery, especially if they are at the same level in the human body. And this necessitates something very important, which is the presence of internal valves inside the veins. We have never talked about valves inside the arteries. There is nothing like valves inside the lumen of the artery. You can have a valve at the beginning of an artery. So you have a valve at the beginning of the aorta, which is the aortic valve. You have a valve at the beginning of the pulmonary artery, which is the pulmonary valve, but there are no more valves along the course of the arteries. They do not need to have valves because the pressure inside them is high. They have high elasticity, and therefore they have a high elastic recoil. So because of the high pressure and because of the elasticity and elastic recoil, arteries do not need valves. So this is a question. Arteries do not need valves along their courses. Arteries do not need valves along their courses. Okay? Now, the problem with the vein is that the pressure in the vein is very low. And especially if the blood in the vein is going upward against gravity, like in the veins of the lower limb, then there would be this flow of blood, which is already very weak, or rather weak, because of the low blood pressure, would be antagonized by the tendency of the blood to pull downwards, because of gravity. And therefore, there should be protection against retrograde pulling of blood towards the feet while you are standing up. And this protection against downward pulling of blood is done via valves along the course of the vein. So this is an important difference between veins and arteries, and by muscle contraction. Suppose this is your lower limb. Suppose this is your leg, and these are the calf muscles, for example, the calf muscles. And here, as the blood passes upwards, the valve, those valves open in order to allow the blood to pass forward. But once it passes, the valve below will close in order to prevent backflow or pooling or regurgitation of blood. So this is the role of the valves. The valves in the veins allow one-way flow as usual. The valves allow one, but here it's always one-way flow of venous blood towards the heart. Are the valves alone in preventing pooling of blood in the lower limb? No, there is another help that is carried out by the tone of the muscles. You know that the muscles are in a status of continuous but partial, continuous but incomplete or partial contraction of the muscles, and this milks up or squeezes up the blood. So if you have weak muscles, then you would suffer from pooling of blood in the lower limbs. And what would happen if your valves are weak and there is tendency of your blood to pool downward? The pressure in the veins would be high, exudation of fluid from the capillaries would be high, and you would have swelling of the lower limbs, which we call lower limb edema. So one of course, we have seen several causes. Maybe during your clinical case studies, you have met cases of lower limb edema, like, for example, right ventricular failure, like liver cell failure. But here we have a third or another cause for lower limb edema, which is weak valves in the veins, weak valves in the veins. Okay. Now, what are varicose veins? Now, many of the veins that lie in your lower limb pass through skeletal muscles, and when the muscles contract, as I said, they will squeeze the blood upward. When the muscles contract, they will squeeze the blood upward through the veins in order to prevent the pooling of blood. And what happens when the muscles relax? When the muscles relax, it is now the role of the valves to prevent pooling of blood. So what happens if you have any of these mechanisms not working? For example, what happens if you have weak valves, or we can say if you have incompetent valves in the lower limb, or what happens if you have weak muscles of the lower limbs? In such a case, the blood will pool downward and you will have like tortuous, engorged, distended. You can use any of these adjectives. Tortuous means that they are convoluted or curved like this, and tortuous or congested. Congested means that they are full with blood and they look like blue snakes under the skin. In Arabic, we say dawali, and this is due to incompetent valves and or weak muscles of the lower limbs. And therefore, when I say weak muscles, I mean weak muscles tone. This results in pooling and accumulation of blood in the lower limb. In such a case, of course, there are several general measures like avoiding standing up for a long period of time. And if you're a teacher, for example, or a medical doctor, and you're forced to stand up for a long period of time, you have every now and then to voluntarily contract your muscles, your calf muscles, in order to milk the blood upward. But in severe intractable cases that cannot be treated by general measures like avoiding standing up for a long period of time and muscle contraction, or even certain medications like vitamin C and vitamin P that strengthen the wall of the veins to prevent the occurrence of varicose veins, we refer to sclerotherapy. And in sclerotherapy, of course, means treatment, and sclero means something that makes the wall of the vein rigid. So sclerotherapy, so you inject those veins that are varicose veins with a chemical, and that chemical damages the internal lining of the vein. Why would we damage the internal lining of the vein? In order to cause clotting within the vein, and therefore the vein would be obliterated forever. Of course, we only refer to this in severe conditions. This slide that shows the patterns of circulation in the human body has been discussed several times, but maybe not on a single setting. So we have the systemic circulation and the pulmonary circulation. The circulation that starts at the left ventricle and then passes through the aorta to distribute oxygenated blood to the whole body, and then finishes at the right atrium. This is the systemic circulation. So the systemic circulation starts at the left ventricle and ends at the right atrium, whereas the pulmonary circulation will start where the systemic circulation ended, or in the chamber that is just after the right atrium, which is the right ventricle, and then will send deoxygenated blood to the two lungs, and then will receive oxygenated blood via the pulmonary veins that will end up by pouring their blood into the left atrium. So the pulmonary circulation starts at the right ventricle and ends at the left atrium. So as we said before, the pulmonary circulation, when you have deoxygenated blood that has been brought to the right atrium from all the body, this deoxygenated blood, as you know, will pass to the right ventricle, and the right ventricle will pass it via the pulmonary arteries to the two lungs. So the pulmonary arteries has two branches for the two lungs, and as you know, the pulmonary artery is the only artery in an adult human body that carries deoxygenated blood. Of course, when the two branches of, so you have a right branch of the pulmonary artery. So if this is the pulmonary artery arising from the right ventricle, so it will have a right artery and a left artery. The right branch of the pulmonary artery will carry blood to the right lung and the left one to the left lung. And then inside, the arteries will divide into arterioles and then into a capillary bed as usual, where exchange occurs in order to unload the blood from carbon dioxide and load the blood with oxygen. But it is worth mentioning that if the lungs receive deoxygenated blood via the pulmonary arteries for unloading via the capillaries, this does not mean that the lung tissues themselves, like the walls of the bronchi, the walls of the bronchioles, the walls of the air sacs, they're made up of cells, and these cells, just like any cells in the body, require arterial blood that is oxygenated in order to obtain their needs of oxygen and blood and nutrients. And that's why not only do the pulmonary arteries provide the lungs with blood, but also the bronchial arteries. But there is a great difference between the two. The pulmonary arteries arise from the right ventricle and carry deoxygenated blood, whereas the bronchial arteries are branches of the aorta or branches of the arterial system, and they supply oxygenated blood. So they are branches of the aorta, but indirectly, of course, they are not direct branches of the aorta, but I'm saying this to remind you that they carry oxygenated blood. So we can say that the lungs, and this is a famous question, have a dual blood supply. We have seen, or we will be seeing, another organ that has a dual blood supply, which is the liver. So remember, these two organs require or have a double blood supply, the lungs having the pulmonary arteries and the bronchial arteries. Of course, I'll not be explaining alveolo-capillary exchange because we have said it several times. You all know the hierarchy. You all know that the pulmonary veins get oxygenated blood from the lungs and pour into the left atrium, then the left ventricle, then the aorta. Now, here we have the need for an efficient pump. So we will discuss together why we need an efficient left ventricle and why we need an efficient right ventricle. But before doing this, we would cover this slide rapidly, the systemic circulation, because we have mentioned it previously. It is the flow of blood between the heart, specifically the left ventricle, and all the parts of the body. And that is mainly done by the aorta that arises from the left ventricle and carries oxygenated blood to all the tissues of the body. Why is it important to discuss the systemic circulation? Because through this systemic circulation, all the organs will receive oxygenated blood, and every organ will have its share of oxygenated blood via its own circulation. So, for example, the heart will receive via the coronary circulation, the liver via the hepatic circulation, the kidney via the renal circulation. So there are subsets of the systemic circulation to supply every organ with blood. And now we come back to the need for an efficient pump. Why is it important to have a good and well-functioning left ventricle? Of course, to supply all the tissues adequately with oxygen and with nutrients. So what would happen if the left ventricle fails, becomes weaker, the cardiac muscles become weaker and cannot pump blood? There will be diminished oxygenation of the tissues, or let's say an important term, which is diminished perfusion of the tissues with oxygen, and this results in tissue hypoxia. It's important to know that hypoxia means a diminished oxygen in the tissues, whereas hypoxemia is diminished oxygen in the blood, because you know that emia refers to the blood. Of course, if you have hypoxemia, then it would result in hypoxia. What are the causes for cardiac muscles becoming weaker, or what are the causes for left ventricular failure? Of course, if you have long-standing high blood pressure, the heart is all the time pumping against high resistance. So at the beginning, it would increase in size, and the increase in size of the muscles, we said before that there is no increase in number, but there is increase in size of individual cardiac muscle fibers, which we call hypertrophy. But at the end of the day, hypertrophy cannot last for long, and there would be failure. The muscles would fail. And if the muscles fail, then the left ventricle will be dilated. So one of the causes of enlargement or dilatation of the left ventricle is left ventricular failure. Similarly, if you have a long-standing valvular disease like aortic incompetence, for example, where every diastole some regurg of blood occurs and the heart receives more than normal blood, then it would be a burden. Or a long-standing coronary artery disease that is not lethal, that is not fatal, meaning that your blood vessels are narrow, your myocardium does not give or does not receive oxygen, but you are not in a serious condition. So if you have a long-standing angina pectoris and coronary artery disease, and your cardiac muscles do not chronically or are chronically deprived of oxygen, then in such a case, they would end up by failing, meaning that they will become weaker and they will not be able to pump blood efficiently to the tissues, resulting in hypoxia. So when the left ventricle or the left ventricular muscles dilate, there will be what we call left ventricular failure. So the left ventricular muscles are no more able to pump blood with adequate amounts of to pump blood with an adequate rate that supports the needs of the tissues of oxygen and nutrients. So there would be two types of symptoms. As we said, I think we covered this in grade 10 last year. If the left ventricle is failing, then the blood that is pumped via the aorta will be diminished. So there will be diminished cardiac output to the tissues. This would lead to a low blood pressure, especially the systolic blood pressure, easy fatigue or fatigability, dyspnea, dizziness, and a rapid heart rate to compensate for or to make up for the diminished oxygen that reaches the tissues. And at the same time, if the left ventricle cannot pump blood adequately to the aorta, then it will not be able to receive blood adequately from the left atrium. The blood would accumulate in the left atrium, and there would be back pressure on the lung, and blood would accumulate in the capillaries of the lung, leading to lung congestion, and lung congestion will lead to three symptoms: dyspnea, because the air sacs cannot distend at ease, being surrounded by congested blood vessels; orthopnea, which means dyspnea when you lie down immediately after you put your head on the pillow, you are forced to sit down in order to relieve the symptoms of dyspnea. And the third one, which is less severe than orthopnea, which is paroxysmal nocturnal dyspnea, which means that after having slept for a certain period of time, you wake up having tachycardia, having dyspnea, having colorless frothy sputum, and it also forces you to sit down and in order to be relieved from the symptoms of dyspnea. These were the symptoms and signs of left ventricular failure, and we grouped them into symptoms due to low cardiac output and symptoms due to congestion or back pressure on the lungs. On this slide, we'll be discussing the importance of an efficient right ventricle. And I think, again, that we covered this in grade 10 last year. So if you have a good or a well-functioning right ventricle, this means that this right ventricle will send the deoxygenated blood via the pulmonary artery to be oxygenated, to be unloaded from carbon dioxide and loaded with oxygen. But it also means that this right ventricle can empty itself of blood adequately and therefore receive blood from the right atrium. So if the right ventricle is failing, if the right ventricle cannot pump blood adequately, we will also have two groups of symptoms. We would have a group of symptoms due to diminished oxygenation of blood through the pulmonary artery, because not adequate blood is being pumped by the right ventricle to the pulmonary artery, but we will also have back pressure on the right atrium because the right ventricle cannot take all the blood and pump it to the pulmonary artery. And this back pressure will be reflected on the superior vena cava and the inferior vena cava, and therefore there will be elevation of pressure in both the superior and inferior vena cava. Clinically, we cannot visualize the inferior vena cava nor the superior vena cava, but at least we can see one of the branches of the superior vena cava, and therefore we can assess this branch of the superior vena cava that if congested with blood, we can visualize not the vein itself, but its pulsations in the neck. This vein we can visualize in the neck, and which is a branch of the superior vena cava, is the internal jugular vein, and the pressure that you measure in this vein is called the jugular venous pressure. When do we consider that the jugular venous pressure is high, or that the jugular vein is congested, or simply that the neck veins are congested? Now, if we place the patient at an angle 45 degrees above the horizontal, and then we measure the vertical distance above the level of the sternal angle, meaning that if this is of course, you know what the sternal angle is. Here we have the manubrium sterni, here we have the body of the sternum, and here we have the angle or the sternal angle. So if this is the horizontal level of the sternal angle, then you measure the vertical distance above that horizontal level, and it shouldn't be, as you know from last year, more than 4 centimeters. It's usually from 2 to 4 centimeters. And usually when you have an elevation of the jugular venous pressure, which is an indication of increased pressure in the superior vena cava, you will also have another indication for the elevation of pressure in the inferior vena cava, because we said that when the right ventricle is failing, there will be back pressure on the right atrium. There will be elevation of pressure in the superior and inferior vena cava. The elevation of pressure in the superior vena cava is visualized by an increased jugular venous pressure, whereas the elevation of pressure in the inferior vena cava is indicated by lower limb edema. So when blood or the pressure in the inferior vena cava is elevated, this will be manifested as lower limb edema, and that's why a patient with right ventricular failure will have congested neck veins and lower limb edema. So in the general examination, you will have both. In the general examination, if you have, oops, sorry, in the general examination, if you have congested neck veins, then most of the time you will have lower limb edema. We will stop here, and next time, inshallah, we will be discussing the coronary circulation and the diseases that are related, which are myocardial infarction, angina pectoris, and the ECG changes that occur, and the rest is very simple. So I feel that we've covered most of the important parts of the circulatory system. See you next time, inshallah. Bye bye.